spinal cord injury and stroke to sort of think through, patient scenario. Um, so you're basically given a patient scenario and asked to try to identify which one of those neuromuscular diseases she's got. Okay, the next question is about pulmonary fibrosis versus um, respiratory muscle weakness. They're both restrictive lung diseases. So pulmonary fibrosis is a restrictive lung disease, so is neuromuscular disease. But the difference is in the pink stuff in the lung, that's where pulmonary fibrosis is in the parenchyma of the lung versus chest wall and the musculature of this chest wall. So how do you differentiate between those two restrictive lung diseases? And in particular with respect to the pulmonary functions and residual volume changes. And what's the minimum vital capacity for a patient that has acute respiratory muscle weakness, like from myasthenia gravis? What's the minimum vital capacity where they need to be intubated and ventilated? Okay, now we're on to non-invasive positive pressure ventilation. And so what we've got here is a question that's asking for the exclusion criteria. So for example, I'll just give you one. It's not the one on the test. But if your face is very deformed, you can't do mask ventilation when somebody's got very deformed. So that would be an exclusion criteria. But there are some exclusion criteria. You probably talked about them in class, right? But one of them is not that their CO2 is elevated. That's kind of an indication for ventilating the patient if you have an elevated CO2, right? Okay, you got another patient scenario. This is one of those ones where there's 3 or 4 questions connected to it. And you got a blood gas, and right, it's an interpretation, blood gas interpretation problem. So this patient has chronic as well as acute issues. So you've got a combination blood gas here, or you've got chronic hypercarbia, and the patient has acute problem that she's decompensating because of that. So you see it in the blood gas. And is this a person that's a candidate for non-invasive positive pressure ventilation? And if you put her on the ventilator, what are the best initial ventilator settings? So appropriate ventilator settings. You can basically kind of group patients for ventilator settings into several categories, like, what are you going to do if there's a COPD patient in front of you? What are you going to do if there's a patient who's completely unconscious, neuromuscular kind of problem? What are you going to do if you have a patient with restrictive lung disease, like ARDS is a restrictive lung disease? How are you going to treat them differently? So you basically can, categorize patients like this, and you can come up with the initial settings for the ventilator. They're really educated guesses about where to put the patient on the ventilator, because the next step is going to be get a blood gas and make adjustments to the ventilator settings. But where are you going to start? So is that going to be pressure control or volume control, for example? So physiologic changes associated with a high auto PEEP. What kinds of things happen to people if they have a high auto PEEP? What are the physiologic consequences of having a high auto PEEP? Intrinsic PEEP. And what are the factors that increase the risk for auto PEEP? So, for example, COPD patients are candidates for auto PEEP because they trap gas, so they get auto PEEP pretty easily. So beyond that, then you need to kind of think about, well, what can we do to prevent them from getting auto peak? So there are a couple things that come to my mind. One is expiratory time has to be as long as possible, and then don't worry so much about the CO2. Just let that go. You know, keep them from prevent them from getting auto peak, to the point of sacrificing their blood gas a little bit for it. So let them get a little acidic and let them get some carpet carbide. So now these problems, there's several problems here that have to do with compliance and resistance changes in patients. So how do those impact the way the ventilator works? So for example, what happens if the patient's lung compliance worsens from, say, ARDS in volume control in pressure controlled ventilation? So what if they get stiffer? What happens to their tidal volume if they get stiffer in pressure controlled ventilation? Right. So so there's respiratory care. There's like 5 problems that are real common, and so compliance changes and resistance changes. How does it affect the pressure, the peak pressure and the dynamic pressure, the static pressure? How does it affect the pressure? How does it affect the volume if you're on pressure control? And how does it affect the pressure if you're on volume control? Those are the common formulations that you see in these problems. So he's got one of these problems here, where he's you know, kind of giving the patient an asthma attack. What does that do to the peak and static pressure? Or he's giving the patient worse ARDS. What does that do to the peak and static pressure? Well, what if you're on pressure control? What does that do to the tidal volume? If your compliance gets worse, your tidal volume goes down, right? If your resistance gets worse, your tidal volume is going to go down on a pressure control ventilator. So, you know, kind of knowing how those numbers change, right, is where you should be in terms of your learning, because you're pretty far along here. So this question is about extubating a patient. And so obviously you want the disease to have reversed to a large extent. You want the patient to have gotten better before you extubate them, right? But you also want them to have good parameters. And so one of the parameters is minute ventilation, spontaneous minute ventilation, right? And also you want them to be aware, right? You want them to have a good level of consciousness. And you don't want them to have a lot of drugs on board, like morphine and drugs like fentanyl and propofol that have high respiratory depressing effects. You don't want that. And you don't want to have to be suctioning them a lot. If you're suctioning them a lot, do not pull the endotracheal tube, right? So those are the things I taught you when we did airway care, those 4 or 5 things there. But you know, here they are again. You need to understand because we extubate patients all the time, you need to know when is it okay to pull the tube. And those are 5 things you should look for in a patient that's ready to pull the tube. So if they fail in any one of those, you need to ask a question, should we pull the tube? Maybe we shouldn't pull the tube. Now, it doesn't mean you won't, but yeah, should we? Okay, another ventilator setup where you get a blood gas, and you have to decide what to change, you know, tidal volume, frequency, tidal volume, frequency, FiO2, PEEP, you know, based on the blood gas. Again, you have to deal with what you have to deal with, so it's, you know, the responses down below are what you have to pick from, so find the best one. Okay, here's a problem. Are you aware that if a person has a partial plug of their endotracheal tube, that what should happen is that the peak pressure would rise, but the static pressure would stay about the same? Are you aware of that? You probably get this question right if you are. So, right. You know, because basically that's a resistance problem. right? Any resistance problem does that. You get that, right? Any compliance problem does that, where both pressures go up together. Or you understand what I'm saying here? Right, so resistance problems, right, compliance problems. And compliance gets better, resistance gets better, top one comes down, right? So if you give them an aerosol and it works, this one ought to come down. This is another blood gas interpretation problem. So, but this one is, the way they frame this one is, instead of you know, basically identifying the patient as a hypoxemic patient with a respiratory alkalosis, it's real common for people who are really hypoxemic to breathe too fast, and they get a respiratory alkalosis. So you know, you might be wanting to find an answer that says respiratory alkalosis, but what they really got is extreme hypoxemia, and that causes the hypoxic drive to kick in, and they start breathing faster, and they blow off CO2, and they get alkalotic. But that it's a respiratory alkalosis, but it's there because they're hypoxemic. If you correct the hypoxemia, the pH and the PCO2 will recover. But you have to be careful not to, you know, adjust the ventilator settings like tidal volume frequency when you've got a patient who's hypoxemic, because the hypoxemia is messing up the pH and the CO2. There's a respiratory alkalosis kind of rule, is watch out for hypoxemia. That's what causes a lot of respiratory alkalosis. Okay, another one of these series problems. Patient scenario, ventilator patient. Looks like he's a wiener. Can you calculate the RSBI? So calculate the RSBI. The trick with that one there is that the tidal volume, I think, has to be in liters, right? Frequency, tidal volume, right? So RSBI. It's a multiple choice question. Please try and get it right. Google it, RSBI. That's what I do every time. Is that frequency over tidal volume in liters, or is it? Yeah. Anyway, following statements. Okay. Readiness to intubate. Readiness to intubate. Is there anything in this story that you're getting that might tell you they're not ready to intubate? So I'm going to go back over it. Say, is there anything in, you know, my list of 6 things, right? Did I mention the fact that if they're on anything more than 50%, you probably shouldn't extubate? So I don't know if I mentioned that one, but if they need a lot of oxygen, don't extubate them, because it's hard to get. Well, plus, they must have a big shunt if, you know, you got that kind of need for oxygen. So anything about 50%, kind of a rule. Another ventilator case. Now this has to do with the use of pressure support. And how pressure support works. So when you know, pressure support is different than pressure control. Pressure control is a full support mode. Pressure support is a weaning mode. And so you got to pay attention to the fact that how much pressure support the patient is on affects their spontaneous tidal volume. So if there are a lot of pressure support, the spontaneous tidal volume can be pretty large, and you might be deceived into thinking that they've got a pretty good spontaneous tidal volume. This is the pressure support. So you almost have to get the pressure support down to about 3 to 5, to know what they're actually doing on their own. Otherwise, the pressure support's kind of keeping them going on the spontaneous breaths. So you got spontaneous and you got controlled breaths, right, in pressure support. Usually that's volume controlled breaths. Volume controlled and pressure supported breaths. Another blood gas. This one's on non-invasive positive pressure ventilation. And so the question here is, when do we give up on non-invasive positive pressure ventilation? What tells you that the patient needs to be intubated and ventilated with a, you know, where do we make what numbers tell us that patient's just not making it? on non-invasive ventilator. Oh, that's the end.